I think someone is sharing the screen. Oh, it's Flora. Yeah, Flora, I think you were sharing the screen. We were all seeing doubles of each of ourselves. Thank you, Flora.
That was a very meta moment.
Really was.
Or if it's possible, this is Mark Atala. I'm not sure if Michelle will share screens or someone else on the board. Or if I'm going to share screens, I just need I think I need to be made a presenter.
Yeah, I think you need permissions. Michelle, how would you like to proceed with that? Would you prefer if Laura shared their screens? That'd be easier.
I am happy to do so if that is more helpful for you, Mr. Atella.
It might be easier for me to work
Okay.
through that. I just
Okay, Susan, are you able
I
to
think,
give him presenter?
let me see, or I don't know if Laura, you can do it. Let me see if I've never done that before, but let me see.
worst case scenario, we'll make it through if Michelle's doing it. Just
Yeah.
maybe.
It might actually, I just realized this. I think Kristen may have owned the meeting, so that might be an issue. I just realized that. So Michelle, if you don't mind doing that, if you don't mind sharing the slides.
Sure. No problem. Sorry about that.
Apparently, I'm overdressed in the world of Zoom meetings. So
Hey, good afternoon. Susan, I'm just doing an audio check. Okay. All right, it looks like we have everyone, so I'll call to order the Green Mountain Care Board's hearing of November 1st. Hope everyone had a nice Halloween. We have one substantive agenda item today. We have Lower Health ACO review. We'll have a staff introduction by Michelle Sawyer, our Health Policy Project Director. And then we'll have a presentation by the Lower Health Compliance Officer and Executive Director. So first, we'll start with the Executive Director's report.
Thank you, Mr. Chair. So first start with some public comment periods that are open. I ask you to look at our Green Mountain Care Board website under public comments. There are several listed there right now. The Lower Health budget open public comment period is on the website, as well as One Care Vermont. So please take a look at those. And look at the dates that we want to have the public comments in order to be put before the board before we make a decision. I also wanted to remind everyone that we have an ongoing public comment period regarding a next potential model with the federal government. Any of the comments we receive, we share those with our colleagues over at AHS, Agency of Human Services, as they are leading the negotiations on the model. And last but not least is we have an open public comment period for the community engagement work that the board is doing regarding Act 167 and hospital sustainability. So there's a link to add a public comment for anyone who may not, or in addition to attending my next announcement regarding community engagement work that the board is doing. We were asked by the legislature in 2022 to provide a very thorough community engagement process to understand the current landscape of healthcare in Vermont. It is going really well. It started about 2 weeks ago. There are nearly 40 meetings scheduled. There's about, we're about maybe a third of the way in. I'm happy to report that the response from community members and providers throughout Vermont has been very robust. So I just want to encourage those on the line who live in Vermont to check out a meeting either in your community or statewide. All of these meetings are virtual for the first part of our community engagement. And it's very simple to find out when a meeting is in your area, as well as how to register and sign up and attend those meetings. So thank you all for getting the word out. I'm really thrilled at the response, and we're very happy to hear everyone's voice in this process. So that is all I have to comment and report out on for today. I will turn it back to you, Chair Foster.
Great, thank you. We had a meeting last, is October 27th. Have the board members had a chance to review those meeting minutes? And is there a motion to approve?
So moved.
And I'll second it. Is there any board discussion? All right, all those in favor of approving the minutes from October 27th, please say aye.
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 Aye. And the minutes are approved. And with that, I'll turn it over to Michelle Sawyer.
Thank you, Chair Foster. I'm Michelle Sawyer, Health Policy Project Director with the board. I'm here to introduce Loar Health ACO. This is the second year they have come before their board to present their budget, as 2024 will be their second year in our state. All right,
Thank
so
you.
let's.
Go
I'm
ahead,
sorry.
Michelle. I'm sorry. Go ahead.
Okay. Let's look at this chart briefly to orient ourselves in the regulatory process as it pertains to Loar Health. On the left, we have ACOs that accept payments from Medicaid or commercial insurance payers. You can see that both certification and budget review are required of these ACOs. And on the right, we have ACOs that only accept payments from Medicare. Because Loar Health is a Medicare-only ACO, they are not subject to the certification process and are only going through the budget review. Loar Health does have fewer than 10,000 attributed lives in Vermont, so the review is based upon the standards and processes that the board deems appropriate, whereas larger ACOs would be subject to all standards and processes established by Rule 5. And finally, as is highlighted in the bottom green box, the Green Mountain Care Board has developed Medicare-only guidance for these types of ACOs with fewer than 10,000 lives. And this guidance is the basis for the review. This slide outlines the budget review process as outlined in statute and rule. In deciding whether to approve or modify the proposed budget of an ACO projected to have fewer than 10,000 attributed lives in Vermont during the budget year, the board will take into consideration any benchmarks established under section 5.402 of this rule. And at this time, there were not any benchmarks set for the Medicare only guidance. Second, those criteria listed in 18 VSA 9382B1 that the board deems appropriate to the ACO size and scope, which we will discuss shortly. 3, the elements of the ACO's payer-specific programs and any applicable requirements of 18 VSA 9551 or the Vermont All-Payer Accountable Care Organization Model Agreement between the state of Vermont and CMS, and for any other issues at the discretion of the board. So the staff recommend that board consider the following factors from 18 VSA 9382 when reviewing Loar Health's ACO budget. Information regarding utilization of healthcare services delivered by healthcare providers participating in the ACO and the effect of care models on appropriate utilization, including the provision of innovative services. the character, competence, fiscal responsibility, and soundness of the ACO and its principals, any reports from professional review organizations, the ACO's efforts to prevent duplication of high-quality services being provided efficiently and effectively by existing community-based providers in the same geographic area, as well as the integration of efforts with the Blueprint for Health and its regional care collaboratives. We also recommend that the board consider public comment on all aspects of the ACO's costs and use and on the ACO's proposed budget, information gathered from meetings with the ACO to review and discuss its proposed budget for the forthcoming fiscal year, information on the ACO's administrative costs as defined by the board, the extent to which the ACO makes its cost transparent and easy to understand so that patients are aware of the costs of healthcare services they receive, and the extent to which the ACO provides resources to primary care practices to ensure that care coordination and community services such as mental health and substance use disorder counseling that are provided by the community health teams are available to patients without imposing unreasonable burdens on primary care providers or on ACO member organizations. These factors were chosen based upon the size and scope of Loar Health. They do have a limited presence in Vermont, and they have a single network participant and a small number of Vermont lives attributed to the ACO. This slide is a reminder of the timeline for Loar Health's FY24 budget review. So today we are having the ACO's budget hearing. Later this month, the Green Mountain Care Board staff will present their analysis of Loar Health's budget submission to the board and include any recommendations at this time. And there is a potential vote scheduled for December 6th. And as always, the board welcomes comments from the public on their proceedings. The deadlines listed here allow the board to consider public comment ahead of each upcoming event on the timeline. First, public comment can be submitted by Wednesday, November 15th to be considered ahead of the staff analysis. Or second, public comment can be submitted by Friday, December 1st to be considered ahead of the board potential vote. And this is the agenda for today. We just reviewed the board's authority and criteria. I'll hand it over to Loar to go through their presentation. There will be time for questions from board and potentially staff, time for healthcare advocate questions and public comment. And if necessary, there is the opportunity for an executive session. So I will hand it back to you, Mr. Chair, and I will pull up slides for Loar Health.
Great, thank you. I'm going to have our attorney, Mr. McCracken, swear in the folks who will be testifying today for Loar.
Thank you, Chair Foster. Mr. Atala, Dr. Brysick, sorry. Are you the only two who will be testifying for Loar today, I believe?
Yeah, we do have outside counsel, Andrew Choi, but he may not need to swear in.
Typically, we wouldn't swear in outside counsel unless he's providing substantive testimony. Sure. So if you two would both raise your right hands, I'll go ahead and swear you in. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Great. Thanks very much. And we will turn the presentation over to you.
Thank you, Mr. McCracken, Mr. Chairman, and Ms. Sawyer. Thank you for that introduction and overview. So I'm Mark Breestocker. I'm a primary care provider and the executive director of Loar Health ACO. And it's a real pleasure to be back with the Green Mountain Care Board for a second year. We've had a really good start to the 2023 performance year. We've got such a great partnership with North Star Health down in Springfield. We were able to spend some time with the team there earlier this year. And I would say it was the first opportunity I had to come to Vermont, and it was a lovely visit and such a beautiful place to come and spend a long week together. So We've also had the pleasure of, through the year, working with other community partners, have been able to partner with some skilled nursing facilities to expand our program for 2024, and have had some very good, fruitful, and encouraging conversations with one of the local area agencies on aging in the Springfield and Brattleboro areas. And so we're looking forward to our budget review today. With that, I want to introduce Mr. Mark Atala, and he is going to lead that review. So over to you, Mark.
Thanks so much, Mark. And Michelle, next slide. So in terms of agenda items, we wanted to go through really three main topics. So just to reorient everyone to really the Medicare SSP program quickly. I'm certainly happy to answer questions there. Talk through us and Lower Health and the ACO, experience, our timeline, just to clarify what we receive and when, and then go through our Medicare only budget submission for 2024, and then certainly happy to answer questions here or in executive session if deemed appropriate by the board. So on the next slide, at the highest level, I mean, the Medicare Shared Savings Program was established in 2010 through statute in the ACA, and it really has the intent to promote accountability for the fee-for-service Medicare population. And so, prior to both, whether it's the CMS Innovation Center or which you have an all-payer model through, or the authority granted in the statute, Medicare fee-for-service beneficiaries really sought care how they did, and it was really up to those providers to ensure that patients were cared for and coordinated. And so through the Shared Savings Program, Medicare is attempting to really formalize that accountability through an accountable care organization to coordinate items and services really under Parts A and B. So Part D is not, which is drugs, is not included. And then also ensure that there's some longer term sustainability through infrastructure and hopefully redesigned care processes. So hopefully fully aligned with the GMCB's mission and aim. That was the statutory creation. The federal regulations are under CFR Part 425. And so there's a suite of things that really all ACOs must comply with there. And that's really the really what establishes what a Medicare SSP ACO follows. With that, as noted in both the regulations and then elsewhere, SSP ACOs must comply with all applicable laws, federal criminal law, False Claims Act, Anti-Kickback statute, CMP law, and then physician self-referral law. And so given that the program is over a decade old, the program is delivering savings both for the trust funds and then really federal taxpayers. And so last year, and pretty consistent with previous performance years, overall saved around $1.8 billion for the Medicare trust funds. Next slide, please. And so for how does CMS manage an ACO? So first, there's an annual application cycle. We do go through the application cycle every year. There's different questions that are asked really for a first initial applicant versus what we can change annually. And so the first review is really for what we went through last year. I think the last time we met, we had not actually gotten approval, and since then we have gotten approval. So we're live for 2023, and so that is a 5-year agreement period, and we're in the enhanced track of the Shared Savings Program. And so as part of any shared savings program in ACO, CMS requires that we establish a shared governance, and so that shared governance is predominantly led by the ACO participants themselves. So they control 75% of our governing body. And then in the case that there's an ACO and a two-sided risk track, so both up and downside risk, which we are, Medicare SSP ACOs have to establish a repayment mechanism before even getting a participation agreement from CMS, and we have done that. And CMS sets what that financial guarantee or that repayment mechanism is. It's either surety bond, letter of credit, or dollars in escrow, and CMS tells the ACO what that amount is annually there. And so, as an ACO participating both now and then in 2024, we've satisfied really all of these federal requirements that we've outlined. Okay, so moving on really to our participation in Vermont. So we have one ACO participant in Vermont, and so the term ACO participant, it's a term CMS uses. So the Shared Savings Program operates at a tax ID level, so a TIN level, and so all providers that bill Medicare under that TIN and that are considered part of that ACO participant. And so as part of that, there's around 3,800 Medicare fee-for-service beneficiaries that are attributed to that TIN, and so that ACO participant. Two of the providers at our ACO participant are part of the ACO's governing body. What that really entails is that they have a fiduciary duty to the ACO, including really the responsibility for oversight and strategic direction of the ACO, and then holding ACO leadership and management accountable that the ACO accomplishes the goals set up by CMS. I'm sure there's a question. No. And then one question that I think we received was a little bit more detail on our participant in Vermont and their commitment to lifestyle medicine. So our Vermont participant has actually 2 boarded diplomats of lifestyle medicine through the College of Lifestyle Medicine and American Board of Lifestyle Medicine. And so how they really work to promote lifestyle medicine is they have both a consultative model where there's one-on-one appointments with them, shared medical appointments with a broader group of patients, and then classes that people can join. And then secondly, really a distributive model where they're training other providers on the core pillars of lifestyle medicine. And those providers, while they may not want to go down the path of getting boarded, they're still exposed to what the core pillars of lifestyle medicine are. And Mark, Dr. Brisacker is actually at the annual conference now. So we had the pleasure of meeting a few people from Vermont there. Okay, next slide, please. So was there one before this? No, you're good. Thanks. So in terms of our experience with SSP and to think through our timeline for budget reviews, we just wanted to give a little bit of what do we receive and how does that work? So, so January 2023 is when we started our agreement with CMS. We get a set of data every month that really is claims information. So that's one thing we process. But really the crux of what we receive is done quarterly. And so quarterly we receive a set of reports that says, here's the beneficiaries that are attributed to you. And so we've elected as an ACO to make sure that the beneficiaries that are part of the ACO are actually receiving care from our ACO participants. And so what that looks like is we get an initial list of beneficiaries who are receiving the plurality of their primary care from our ACO participants, in this case, our Vermont ACO participant. And that changes over time. Those beneficiaries can be added, they can be removed. And so we receive that really every quarter. And then with those quarterly reports, we also receive for that full set of new, really the new set of beneficiaries. Again, most of which are old or have been attributed to us previously, some of which are new, a sense of what their actual expenditures were for that previous 12 months. And so that previous 12 months starts rolling. And so, as you can imagine, given claims lag and other pieces that, for sure you see in other parts of your regulatory experience, we receive really reports starting around April for 2023, and then actually after the performance year. And so just from a understanding, what do we have as of today, even, we really have data through from these quarterly reports really through June. And so We're hopeful for more data this month, but that's just the general cycle to frame for the board. Next year, we'll submit quality data to CMS. So CMS has a set of, we are as part of an advanced alternative payment model, we are actually a qualified, our providers have hit a qualifying participant status in the QPP program. And so they're exempt from MIPS, but the ACO reports quality metrics on their behalf. And so as part of that, we'll submit our 2023 data at the beginning of next year based on CMS requirements there. Then we expect for the 2023 year, so risk scores are not final until generally the very end of Q2. And so CMS will give us our ACO results both for quality and cost in 2020, around July or August of 2024. And so that's the general timeline that we operate under, and hopefully that provides some good color for the board of why we either do or don't have certain questions that you may be thinking about. Okay, so next slide, please. It's similar to what we shared last year. So shared governance. So we have 75% of our voting is held by ACO participants. 25% is by beneficiaries, consumer advocates, or the ACO leadership. For how we are assigned beneficiaries, so again, it's because those patients, those beneficiaries are getting care from a specific TIN. That care is they're getting the most of their primary care from that TIN, or they've chosen to voluntarily align themselves with a TIN or a provider. And that changes quarterly. So we'll receive a final list actually after the year, but we're caring for everyone that we're currently aware is part of the ACO. For 2024, we are adding a new waiver. And so CMS has not given final approval on this. They'll do that at the end of their second phase of applications. The SNFs themselves have been approved. And so we have 2 SNFs in Rutland. And so they've, if we do have waiver approval, they'll be our skilled nursing facility affiliates for the skilled nursing facility 3-day rule, which allows patients to not to have access to the Medicare benefit for a skilled nursing facility without having a 3-day stay, 3-day inpatient stay. For our risk model, we're part of the enhanced track, as I mentioned. And then we've established a minimum savings or loss rate of 0.5% that's consistent with last year. And then this last slide. So the way that we think through our general financials, and happy to work through this with everybody. So in Vermont, we expect this to be around 3,800 beneficiaries. As we annualize that, it's not purely 12 months, people pass away. So we use a little bit of a factor there, but you can think about it as 12 months. So we tie that into essentially member months. And so it's about 44,000. When we go through where our patients are and their expected costs plus expected trend increases from CMS for 2024, we're expecting around $9,900 benchmark per person annually. And so our expectation in terms of benchmark, and so this may be a little bit of a change from how to think about it. So CMS will set really the benchmark to say, what should your expenditures have been for 2024, and that's our assumption on benchmark. And so then from there, we will either achieve some savings or some losses. Certainly, we don't know where that will head. And then the way that we'll either pay money or receive money from CMS, if we receive savings, so it'll be the percent of shared savings. So that'll be a TBD in 2024 times our benchmark. So if the benchmark's 36.5 million, it'll be the shared savings percent times that. We'll also have a quality performance score, and then CMS keeps 25% and they share 75% with the ACO. And so the ACO in the current enhanced track doesn't receive all the savings, CMS keeps a portion. If there's losses, very similar formula, but Based on the quality performance score, the ACO, may only pay 40% of those losses, and there's caps there. Just to give you a little bit of a sense of 2022 results, there's about 480 ACOs in 2022, as I mentioned earlier, than the 1.8 billion. Of those ACOs, I think the average savings was around 3.8%, and for the ACOs that had savings, it's about 4.8%. So the majority of ACOs, I think it's around 85% achieve savings. So just in terms of the model, it seems to be successful in driving improved utilization broadly. But happy to answer questions and have a dialogue.
Great, thank you both. Ms. Sawyer, did you have any questions that you want to start with, or did you just want the board to go first?
I do have a few questions, if you don't mind, Chair
Please.
Foster.
Yeah,
Great.
please.
We had sent Lohr Health a series of questions in response to their budget submission, and there were just a couple that I was hoping to get a little bit more clarification on. We had sent a list of quality metrics. It was in Appendix D, which for the public, the guidance is available on our website if you wish to reference it. And we had asked Lohr Health for their feedback about the feasibility of potentially reporting on those metrics. And you all had responded by recommending aligning our reporting with that of CMS, which we understand. However, we were curious about if it was to be requested by the Green Mountain Care Board, does the ACO have the ability to report Vermont specific results for any or all of those metrics in Appendix D, given whatever CMS is sending to you as far as data goes? We're curious about hearing what steps would be necessary in order for Lohr Health to be able to report those performance on those metrics.
Yeah, it's a good question. So I think if I just to repeat back the question, it's helpful to know, CMS already providing us with that information. Could we then parse it out specifically to Vermont, or would it be a set of administrative analytics, et cetera, from data and that we'd have to pull from? Is that fair?
Correct. I think it would be helpful to know how much of both a burden it potentially could be, or if it is not a huge,
Sure.
lift for you all.
Yeah, we totally appreciate the question. So if we had received this data from CMS, and we certainly receive a lot of data, it's not data that I'm aware that we receive it. And so we can do analytics to get to the metrics that you've requested, especially around the ambulatory sensitive emissions. And so I think we're certainly able to do that through analytics. It may require us to hire an outside contractor to help us get there, but we're certainly able to, if it's the board request it, we'd like to meet your request. But it's not data that I'm aware that we received from CMS today.
Okay, so potentially what they send you after the end of the program year might allow for that data to be analyzed and shared?
I don't think so. So I think
Okay.
What we receive from CMS really is claims data, and we receive data that shows us our utilization. There's not a breakdown of potentially avoidable emissions by hypertension, like by all the disease states mentioned. That being said, they're areas that we've looked at, and so we feel like we can get you the information. It's not data that shows up directly from CMS that we could say this is Vermont section, and then here's what that looks like. But
Okay.
I think we could get there if it's something that the board really is tracking. It would just cost us dollars and time.
Maybe Ms. Sawyer, what I would add is we are just to maybe reinforce what Mark said was that we'd be interested in receiving what the measures are that you're interested in, and then having a conversation about what's possible and really focusing on what's the objective or the goal of that information and what insights are you looking for? Because that request might be the best way to provide that. And maybe there's another view or another analysis of performance that would also answer that question. So we would be open to having that conversation.
Sure, great, thank you both. That's very helpful insight. Great. I had a question about just your model of care. I was curious if you could speak to how much care coordination plays a role in your model, and if it is a pillar of Lohr Health, is there a way that your ACO promotes its practice and its network of providers? And if it is, do you track rates of care coordination in any way?
Mark, do you want me to take that?
Sure, Mark. Oh, happy to come behind.
Yeah, so we do provide a report to each of our ACO participant groups that gives them information on which beneficiaries have been in the hospital, which have been in the emergency department, what conditions they have, what medications they are on, and then we meet with each of our North Star Health every 2 weeks to have it's essentially a operations coordination call, and we present the information to them, and given the claims, the data lake that Mr. Atala shared earlier, this is a process that has just started up, and we had our first call, and it was well received. With respect to, do we track coordination events? No, we don't do that. We 100% agree with, and we are always curious about. We agree with the idea, and we are curious about how and understand what are the care management functions and capability of each of our partners. And in fact, when I was in Springfield, I had a chance to meet with that team earlier this year, and I can tell you that it's something that's really important to each of our partners as well. But we don't actually track those events. I would say the ultimate outcome that we are looking for is better health of Vermont Medicare beneficiaries, better understanding of when to access the right care at the right time, and ideally over time we will see a decreased utilization of the emergency department and a decrease in primary acute admissions. That's how we'll know if all the care coordination that's both happening at the partner level and then our work in terms of supporting them with data and actionable actions to take is making a difference.
Just one additional point too. So as we mentioned with the 2 skilled nursing facilities, we're hopefully bringing online if CMS approves our application. So we'll have kickoff and coordination calls there to say, here, this waiver is now available for this set of beneficiaries. And so what our hope there is that we work with discharge planners or emergency room or even before that to make sure that people are aware that you don't need an inpatient stay, you don't need to stay for 3 days if you do need the additional level of care that a skilled nursing facility could provide. So I think that's the other piece. So we certainly track that is data that CMS provides us. Essentially over the last year, how many times has Mark Atala been in the ER? How many times have I had an inpatient admission? Then where am I? What home health agencies am I using? What skilled nursing facilities am I using? And such. So that we're hopeful that that's an impactful addition for 2024. And Michelle, does that help answer?
It does. Thank you both. And I'd have no further questions. I'll hand it back to you, Chair Foster. Thank you.
Great, thank you. I'll open it up to the board members for any questions or comments they may have. Member Lunge, I see you unmuted. And
Yes,
Dr.
I have
Merman,
a couple, but I was waiting to see if Dave wanted to go first.
I think it was
I just
close,
have-
but I'm gonna call it. I'm gonna call in favor of Member Lunge. I think she was first.
Okay,
It was close. It was close, Dave.
well, thank you. I'm quick on the unmute button, I guess. Hi, all. Thanks for joining us today. I had a couple questions about the 3-day SNF waiver and what you've mentioned a little bit about what you're thinking about in terms of implementation. I was curious how/why you picked 2 SNFs in Rutland, which is an hour and over a mountain range from Springfield. So I was just curious about that choice and how usable that would be given sort of the geography here.
Yeah, I mean, I thank you for the question, Ms. Lunch. And one of the requirements of skilled nursing facilities to participate in the waiver is they have to be rated a 3-star or higher. So we start with that list. I mean, in the ideal world, every SNF would be a 3, 4, or 5-star SNF, and we would be able to have broader coverage. When we realized what the options were, and then of course we reached out to all the skilled nursing facilities and got great assistance from North Star Health in making introductions. There also is varying levels of interest in participating, so that decreases it as well. In the end, the decision point was, do we go ahead and get started, even though it's not the ideal, so that we can learn and we can get the right operational processes in place, or do we wait a year? And we obviously decided let's just go forward and learn. And an objective for 2024 is to continue to have conversations with other skilled nursing facilities. And then we'll actually be able to show them that we do have some who have already started, so they won't have that I'm not sure if I want to go first or not type of decision point. And then we can expand it. And I hope to report back to you in a year's time that we now have even more skilled nursing facilities joining.
And if we can make a plug, I mean, there's not a change. And so in terms of what the waiver means, it means that when they submit their claim to Medicare, they essentially add a payment modifier that says, we understand that this patient doesn't have a 3-day qualifying stay, but they're part of the ACO we've checked. There's a whole set of things that, needs to verify that the person, deserves or needs SNF care, et cetera, and that it's appropriate for them. And so I think from that end, in this case, we're part of it was partnership with North Star, and it's part of that care coordination of where do they already know some of their patients live, and then where it may care be tougher to get to. And so if you can avoid an ER visit and go straight to a SNF that's nearby, that may be an ideal scenario for some patients. But certainly we'd welcome other skilled nursing facilities that want access to the waiver to reach out to us.
Thank you. I was also wondering if you could provide a little, some examples about the in-kind incentives that you offer to beneficiaries, just to give us like a sense of what types of things are we talking about here?
Sure, we'd be happy to do that. So the in-kind incentives that we offer are the types of things that just help people understand how they're doing on their own personal health journey. And there's a couple of home-based tests. I'll give you one example. So chronic kidney disease is it's a really important health topic. It is not it's underdiagnosed. So a lot of people walk around with the early stages of chronic kidney disease, but they don't feel sick. They feel just fine, and they don't even know that their kidneys have started to not work as well as they should. So we offer a home-based test that where they can administer itself. It's an FDA-approved test. We have a great partner that provides that, and they then can find out themselves, and if it's normal, they know right away. If it's abnormal or highly abnormal, which are the three results that the test provides to them, they are then encouraged to through the app to go ahead and reach out to their primary care provider. We get a report of the results, and if we have permission from the patient to contact their providers, we always check that from a privacy perspective. When we get the result, we then reach out to North Star and let them know that one of their patients had an abnormal result. Year to date, almost 50% of our Medicare beneficiaries who have done this test have had an abnormal result. And I just got to say, this is just so, it's just, even if we have one person this year who understood that they have kidney disease and got in with their clinical team and got on the right therapies that can prevent the progression of disease, and even maybe this was their moment to say, I'm going to change my lifestyle and I'm going to start walking more and I'm going to eat a little bit better. I'm going to think about my sleep. I'm going to think about and work on so that I have a normal, healthy amount of stress in my life. If this was the event that made that happen, then we have accomplished so much in that moment. So that's one example of the in-kind incentives.
And just broadly, the in-kind incentive, just as a reminder, for us, it has to be something that's not covered under Medicare. So if it's something that's a covered benefit, we can't offer it as an in-kind incentive. So there are items that are related to the person's health, and then again, not covered. So if the board chooses an executive session, we're happy to offer additional detail if desired.
I have a bit of a technical question, so I'll ask it and you can let me know if it's too technical, but I was curious about the CMS HCC risk adjustment and whether what you think about that methodology, and if you're finding that risk adjustment methodology to be representative of the population. I think there's been some criticism of that methodology in areas with access issues, for example. So I was curious if you've dug into that to see if that methodology in the shared savings program is working for you.
Yeah, I'll offer you probably maybe a different answer than what you'd initially hoped for. So they proposed actually a new model for 2024. They're phasing that model in over 3 years in Medicare Advantage. It's in a proposed rule for this year. That rule has not been finalized. So we're actually not sure which approach CMS will take in terms of HCC scores, and HCC, just for others, the public, hierarchical condition categories. So the way to try to take into account the conditions that a provider, because the person has to their spending. And so, there'll be a standard spend and then multiply by their risk score to give what their spend should be for the year. And so I think I think criticisms of the HCC score is that they work very well around the middle, and they don't work very well on the two tails. I think the considerations to think through, broadly, I wouldn't give anything, is some providers. So for example, an FQHC doesn't bill a Part B claim, they bill a Part A claim. And so they may be less adept at submitting diagnosis claims because a Part B claim captures I think up to 10 HCCs. In the case of an FQHC, their payment may not be different, and payment's not different either. In either case, the way they submit the claim doesn't really lend itself to submitting HCCs. And so you can read into that, would you find some providers potentially the record that they've submitted doesn't match what the actual acuity of the patient is, which means that in theory, the patient, us as an ACO looks potentially worse than the reality. And so, I think those are all parts that that could exist. I think the way that we think about it is we're not the provider, and so unfortunately, we're not able to code. And so I think we very supportive of a complete medical record, an accurate medical record. I think the model itself, we'd reserve judgment and leave that to the health economists at CMS and a lot of others in the industry to get to opine on. I don't think our model is. We're living in the model, so we're if it works, it's great. If it doesn't work, we can't request a change. So
Yeah,
not really in
of
our
course.
control. Does that hopefully that gave you maybe
Yes,
more than
thank
you
you.
wanted?
Nope,
Okay.
that's great. I think that's all I have for now. I may have lost one question, but I'll turn it over to Dave and I'll let you know if I'm found anything else. Thanks.
Yeah, thanks. I just wanted to sort of expand a little bit on the SNF engagement. You mentioned in the opening remarks that you were partnering with skilled nursing facilities. Is this partnership in relation to the 3-day waiver? Are there other layers of the partnership?
That it is in relation to the 3-day waiver. There are parts of that part of the regulation where there are some operational things that we will work on, focus on obviously on coordination and knowledge of which beneficiaries are in their ACO, and then there's some standards to meet in terms of communication and coordination. And so we will certainly, that's the purpose of the upcoming coordination calls, is to begin to work with them on those things.
Okay. Are there any incentives for skilled nursing facilities to partake in the 3-day waiver or more with you as an ACO?
Well, I think if I were to put myself as the medical director or the operations leader of a skilled nursing facility, the incentive that I would see is I can partner with a value-based care-oriented organization in Lower Health ACO who is caring for 3,800, partnering in care of 3,800 Vermont beneficiaries. And to the extent that those beneficiaries, if they get to a point where they need to have additional support through the services I provide, that those beneficiaries are going to be directed to me because they do not have to be admitted to the hospital for 3 days before that admission occurring. And so that would be the kind of, I think, the business imperative and opportunity that I would see if I was a SNF operator. They of course still go ahead and submit their bills for the bed charges and all the services that they provide to CMS, just as they would normally do.
That's all I have at this time. I hear from my fellow colleagues.
I don't have any questions myself. Member Holmes?
Yeah, just have a couple, maybe 2 quick questions. One is, you do talk about a focus on health equity in your narrative, and I'm wondering if you've been starting to measure or have collected any data on the uptake of these in-kind incentives by socioeconomic status. Any evidence that these in-kind incentives are going to have potential to close the health equity gaps?
Yeah, I mean, I think broadly the way we've thought through that is really by the partner we have and the general population that would receive care in FQHC may not, doesn't reflects a population that may have greater socioeconomic needs than other providers. And so from that end, one thing we've focused on is, and we're again happy to support you to enter into an executive session. We've looked at what are areas that could be meaningful to a person address health equity gaps, and then how do we help in ways that the general Medicare benefit just cannot or does not today. And so that's been how we've thought through it. In terms of uptake, I think we've seen pretty consistent uptake across the population, but not so nothing stands out in terms of how we may define a lower socioeconomic status beneficiary versus non.
And Ms. Holmes, first of all, thank you for asking that question. It's important to us. That's why we included it in the narrative. And we're early, we're very early in terms of being able to measure some of these things. And in fact, the clinical team that I lead is working on, what are the proof points from a health outcomes perspective that we want to be sharing in about a year's time when we have had a lot, both more experience and more participation, as well as more time to begin to actually have enough to do these types of analyses. So your question actually is timely in that it helps us add this to what are the things that we should be looking at. And so thank you for asking.
Well, I look forward to seeing, maybe that this time next year we'll have more information on that as you're thinking about the design. I guess my other just question is around, the narrative described no real plans for expansion in Vermont. And I'm curious as to why, to some degree. I mean, it seems like there are, I'm an economist, so I'm going to say this: economies of scale to achieving scale, literally, or to expanding. So I'm wondering, you're in 4 different states. Why not focus on one state and expand within one state?
Yeah. So we would love to. And in fact, we had earlier this year, we had conversations with another provider in Vermont as they were contemplating joining an accountable care organization. And it would be my preference to be reporting that we've added another partner in Vermont today. So we're very open to speaking with anyone to grow, to be able to partner with more organizations and serve them. I think even in terms of what I had shared in terms of our outreach to the area agency on aging, as well as the SNF conversation, is examples of our intent to work broadly within the community, because that's where people live, learn, work, play, and pray, and that's where we want to be connected to the right people in all the right ways. So again, maybe next year we can report that we've had growth in that area, because we certainly, in fact, even today, yesterday at the American College of Lifestyle Medicine conference where I'm at, I spoke with a provider in Vermont and we actually spent 30 minutes together talking about what Laura is, and I was curious about what she does and her type of practice. Learned a lot, and we're going to have a follow-up conversation based on that.
So if you just to put the hat on of one of those providers or a provider in the state of Vermont, what would you say would be an obstacle to joining LOR from their perspective, or what would be a barrier? Why not jump in?
Just to clarify really quick. So that was a change in our narrative response. I think the question itself, asks, do you have active plans to expand in Vermont? And I think our response this year was we do not have an active campaign in Vermont, but we are open to partnering. So just to add additional context. So I think, sorry, Mark, go ahead.
Yeah, no, thank you for that. I think that really there's the main barrier is time and like space to actually think about doing something differently. Everyone's working so hard, and this is true of so many conversations we have across the country with potential partners, and so it's time and where on the list of their most compelling priorities would this type of work and decision-making process fall. And so we are undeterred by that. We have those conversations. We stay in touch, and what we consistently get are answers like, not now, but come back in 6 months and let's talk again. And so I think it's both a reflection of time and waiting for maybe for us to have a little more experience so that they can see us doing the things we said we're going to do.
And I think value's been tougher for some providers to move into. I think from our end, we handle really most of the administration of the ACO, right? So from a provider perspective, I think the things that they should be considering is, how difficult is it to understand the contract I'm entering into? How difficult is it, what's required of me? What are the financial risks? Is there downside risk to me, upside risk? Well, like those types of questions. Again, the broken record. Happy to talk to them in the executive session. Those are the things that from a provider end, I think they should think through, which is Mark's exact point, which is the prioritization piece. I think as QPP and additional financial sticks start entering the fee-for-service program, I think providers will be more and more incented to actually say, okay, I need to join some kind of model for my fee-for-service beneficiaries. And so I think from that end, I think we're an attractive option.
And Mark, you've used QPP a couple of times. Will you just tell them what that acronym stands for?
Yeah, sure. It's a quality payment program. So it's how does CMS manage from a fee-for-service beneficiary perspective, quality for those patients. Thanks, Mark.
Thank you very much.
Is the app, do you consider the app an in-kind incentive?
It is not covered by Medicare. It is beneficial for their health. So yes.
Okay. Any questions from the healthcare advocate?
Yes, good afternoon. Sam Peisch with the healthcare advocate. Can folks hear me? Okay. Okay, great. Just wanted to first thank Michelle and Russ at the board for all the work you guys have been doing on this. First couple of questions are follow-ups based on your responses to written pre-hearing questions. The first one, in response to a question about whether LOR is expanding community-based provider capacity and avoiding duplication of existing services, you said that, quote, the ACO participant maintains relationships with access navigators and others in the community to add resources for Vermont beneficiaries to understand how better to access care. I'm curious what you mean by resources. What resources are being added for Vermont beneficiaries?
Yeah, so right, it's a good question. And thanks for that. So from our end, we again provide to our ACOs, an ACO participant, information on where their patients and where their patients are getting care, and so they can now AC patient X, or a lot of patients use this care network, et cetera. So in terms of resources, they now have access to a set of data that they didn't have without the ACO. So that's one. They could have some information through your HIE, but that may be limited. I think from a financial perspective, if the financial arrangement between us and our ACO participant is positive for that ACO participant, then they now have additional dollars to care and establish infrastructure on site in Vermont. So that's the hopefully clarifies resource perspective.
Yeah, thanks. That's helpful. I mean, I spent some time reading about LOR's rewards and like the LOR dollars, and it wasn't clear to me like how those could be spent.
Yeah,
is that related to
we may want to. Yeah, I'm not sure where that was. Yeah, we may talk through that separately.
Okay, it was just on the website.
Sure.
I'm wondering if LOR believes at a high level that a central problem for patients in Vermont is that they don't know how to access care. Because I mean, in that response, you say to add resources for Vermont beneficiaries to understand how better to access care. Could you just elaborate on what you mean by that?
I don't think there's a presumption that says they don't have access care. I think the better access care is do I have access to my provider, and does that provider have enough? Are they adding providers into their staff, or is it a 6-month wait to get to be seen. And so from a so I don't think I wouldn't read our response was not meant to indicate that. So I apologize if that was your takeaway.
No, that's okay. That's the importance of clarifying and asking, so I appreciate it. Another response that you gave is you said, by virtue of being an ACO, both the ACO and our provider partner are incentivized. This is similar to Member Holmes' question around health equity. You said they are incentivized to bridge access and care equity gaps in the population. Patients can access items and services to narrow health equity gaps. I'm curious about the by virtue of being an ACO element. I'm wondering how you feel like by definition that means that Laura is able to bridge access and care equity gaps.
Yeah, I mean that one is actually by statute even, so and regulation. So the entire purpose of an ACO is to say you now have a set of providers and us that are now accountable for both the care of those beneficiaries and cost and utilization, and then also the quality of that care. So, you know, if the ACO does not deliver both improved quality, or there is at least maintain quality, and then reduce cost, the ACO doesn't sustain. And so, by virtue, the entire program is meant to make someone accountable for the set of fee-for-service beneficiaries that otherwise, you know, would simply seek care and, you know, other than in a non-systemic way, you know, wouldn't necessarily have access to the things that ideally any ACO participating in Vermont or elsewhere is trying to do. So it is the program. I mean, that is a value-based care program. So I don't, yeah, I mean, we'll stick by the answer. It is, I mean, that's the definition. That is the statutory point of having this law to allow entities to help improve, you know, utilization and quality for fee-for-service beneficiaries. So, I mean, that is the program.
Yeah, no, I understand the definition. I guess for me, I would draw a distinction between what the definition of something is, and I guess what I'm trying to get at is how does the value-based care arrangement that you're talking about advance health equity? How does it? Because simply by definition, being something is different than causing or, you know, instigating an impact on something else.
Yeah. So
in my view.
Yeah. Sure. I mean, I think we've aligned incentives, and so in the case of any beneficiary that you know, to the extent it's possible that there are equity gaps, with an ACO should, you know, it's hard for me to imagine a case that with an ACO is worse than without an ACO, and so you know, that's just the view that you know, I think we take in previous roles I've taken from a CMS perspective.
I'm just curious how you evaluate, make that value assessment. How are you measuring, defining success relative to not being in an ACO relationship?
I may be missing the question, Mark. I don't know if you want to.
Well, yeah. Let me see if I can take a swing at this. I think so first of all, the fact that we think it's very important that our interventions work for as many people as possible, and going all the way back several years, you know, the initial ideas were piloted with our FQH, Federally Qualified Health Center partner in San Diego County, because we wanted to make sure that the approaches we were taking worked for almost everybody. So we have 3 federally qualified health centers in the ACO overall, and it is our intent, and maybe linking to the question that Jessica asked earlier, it's our intent to understand from a proof points perspective, we want to prove that this does work for as many people as possible in all circumstances that they face. And so the fact that we have additional, just as one example, the fact that we have additional information about how Vermont Medicare beneficiaries are accessing acute care services to be able to get on the phone then with the leadership team at North Star and say, hey, let's look at our list of beneficiaries who have been in the emergency department 3 or more times. We actually do that, you know, from my perspective, it's like we want to reach out to every one of those people. So I guess, Sam, my assumption is we're reaching out to the broad swath of Vermonters who are on fee-for-service Medicare, and we're going to help them with their clinical team partners identify the things that are leading them to end up in the ER as often as they are, and we want to fix that for them. So we will, you know, based on the data that we have access to that we receive, we will reach a point where we've done this for long enough and we have enough experiences where we can begin to look at it from any number of demographic factors to understand if there is a disparity in results that we're seeing. And then we can have a conversation about why do we think that's happening, and frankly include the Medicare beneficiary in that conversation, so that we have their perspective as well. Does that help a little bit?
Yep. No, thank you. I appreciate it. I'm wondering if it's possible to put up the redacted appendices, because I just had a kind of high level question about the changes in financial performance.
Yeah,
between
so we've actually submitted another. I mean, I'm not sure, Michelle or Russ, how you'd like to handle that, because we've actually submitted a second request based on further information we've understood process-wise.
I'll just
So
note that we pulled down the original redacted version you sent us when you sent us the new confidentiality request. So we will need to receive an updated redacted version of that so we can repost that to the website.
Sure.
I may have an executive session question is what I'm hearing.
It may be, if the board chooses.
Okay.
I don't exactly.
Yeah, go ahead.
Sam, is there a way to ask it without executive session, or do you need executive session to ask the question?
I mean, I'd love to ask it in the public session. I mean, the request just came in recently, so I'm not a lawyer. I'm not at liberty to really opine on whether or not it's fair game. I mean, I was mostly curious about changes at a high level.
We can. So if you have like a broad, like if the broad question is why would our projections change over time, we can answer that and see if that meets your question publicly. So so certainly we submitted a budget last year to the board. You know, we've submitted also a resubmission in March, April of this year, just based on initial uptake. So we now have actual experience, and so I think what you know, we're able to see how many patients are able to actually join LOR, how many patients are utilizing different parts of us and what we offer, and so I think from that end, we're now giving you projections based off of real world experience, and so that's when you see what's changed in our submission. It really is it's just a reflection of, we gave you our best guess last year based on our experience, and we hadn't implemented. We began implementing really January of this year, and we've seen we've learned from that, and so I think from our end, where we're really encouraged is I think our partners now, you know, they've developed momentum. And so that, you know, their providers understand what the ACO is, they understand what the program is, and what the additional in-kind incentives available to their patients are. And so now they're able to have those conversations. And we're seeing really what we hoped for, which is you know, a pretty substantial increase in you know, patient engagement and uptake. So I think from that end, we're encouraged there. And so I think what you see in you know, the broad submission is our assumptions around, you know, what we think are better assumptions based on our current trajectories of what 2024 should look like. So I think from that end, we're still that's what we're tracking to, but I don't know if that's sufficient. And Mark, feel free to add from behind, please.
Okay. I had a couple questions. The last thing about beneficiaries' access to the platform and whether or not you track that. Would Laura prefer to answer that in public, or is that more of an executive session question?
We do not track that. We track every beneficiary has a choice to join LORE, so that's their choice. So the parts that we track are who's actually joined, and then from that end, it's their choice, it's their preference that they choose both to join and they choose to continue to find value in working through different parts of their health, in part with us, in part with their providers.
Okay. Do you feel like the app is the primary mechanism by which LORE hopes to, make inroads, improvements in quality, health outcomes, that sort of thing? Is that like a major vehicle, or is that, just a part of the care model?
Yeah, I think we meet people where they are. So if they're able to engage in the app and join a community of people, that's certainly our preferred path. They still keep their relationship with their providers, and that's standard. And so we hope that is enriched. And we really are just sitting beside that. I think for people that are, non-digital, their digital health literacy may be, or the access may be limited to non-existent. We have accommodation and accessibility pathways that we work with them on. And so I think from that end, our general view is that people that are thinking about how their decisions and how they're and learning about how their health is impacted from diet, exercise, sleep, go down the list, stress. I think the question commonly is childhood trauma and how that impacts over time someone's health. So we look at that as broad chronic or systemic inflammation that has sequelae and disease. I think all of that is a focus of the broad approach that we take, and I think that the way the medium that's affected by or affected in is a combination. Sometimes people will join the digital community. Sometimes people will do that, in a non-digital way that is more them and reflections on their own engagement with the things that we help provide them.
Okay, thank you. Those are all my questions. Appreciate it.
Sure. Thank you. I'll open it up to public comment via the raise the hand function. Walter, did you have anything? I saw you appear here.
Hi. Thanks, Owen. Yeah, you've got me pegged. Most of my questions the board and Sam have already asked, but I was concerned about a couple things with this LORE Health. One of them is transparency. Are you or are you not a direct contracting agency, a private equity firm? Second to that is exactly where are you headquartered? And this picks up off of Jessica's question. Third, is there
Could we by chance answer each question? Just I won't remember them. I want to make sure we answer each. Is that okay, Mr. Carpenter?
Mark.
Okay.
Go for it.
I think your first question is if. Oh, sorry.
Where are you headquartered?
So the ACO is headquartered in California, San Diego.
I saw a list on the web that said you were in Hong Kong.
We are not in Hong Kong.
That was Gather Health, which is formerly your parent. Who are your investors?
So let me interrupt. Let me do it this way. Walter, why don't you go ahead with any comments or questions you may have, and then I'll see if there's any that I want to pass along to the folks from LORE.
Okay.
Yeah, that might work a little better.
And when we say transparency, profit and loss statements, what are the CEOs compensated? Because this is obviously a managed care type thing, for lack of a better phrase right now. Do you or do you not deny claims? And I ask this too because my Medicare prices are almost doubling next year. And when you say beneficiaries, I wonder if we really are a beneficiary, because we're being forced by the federal government to pay this. And this is another middle person within the doctor-patient Medicare relationship. So I'll leave it to Owen. But the transparency is, as a patient, the transparency is the one I'm looking at.
Can I maybe answer one question, Chair Foster, and then just to
Please.
clarify?
Go ahead.
So yeah, Mr. Carpenter. So just to orient this, so we are not a managed care organization. So that would be in the context of Medicare, generally what's called the Medicare Advantage plan. So we are not a Medicare Advantage plan, and so go ahead. So we do not have the ability to deny claims. We don't have the ability. There's no network. So someone who is entitled to Medicare, they're a beneficiary of Medicare, has the option every year to choose a private plan administered through Medicare Advantage. They have the option to remain in fee-for-service. We are not a middle. We're not in the middle there at all. What the middle there is, assumably, you have a relationship with your provider. We partner with providers, broadly, and then if you're a patient of that provider and that's who you receive your primary care services from, we can only do things that are additive to try to help you be healthier. But you can choose not to engage with it. You can still maintain your relationship with your provider, but we don't. Medicare is your coverage if you're in fee for service, which it sounds like you might be. And so if you're fee for service, if your Part B premium is going up, that's in regards to just general cost inflation in healthcare. And I think broadly the Green Mountain Care Board is trying its best to address inflation in Vermont, but sometimes there are things that are federally based in terms of price increases from actuaries. So new drugs that come out, so Alzheimer's medications, for example, drive up premiums. So those are things that aren't controlled by us and certainly aren't controlled by the Green Mountain Care Board. I don't know if that helps. Just to clarify the record, if there's a Hong Kong-based Gather Health, we wish them all the luck, but that's not our parent organization and that's not us in any way. So we, that's that. And we certainly wish to be as transparent as we can be. Certainly with questions like this, we're happy to be transparent, but we're, we are in a competitive space. And so we want to make sure that we sustain. And so whenever you hear us answer a question, we're trying to make sure that things that we are building, we can build on and actually have hopefully a successful organization over time. We are not a direct contracting entity. I think your question there, we are part of, again, the shared savings program for Medicare. But Chair Foster, I yield back to you.
No, that was really helpful, and I hope that addresses your questions, Walter. And if I recall correctly, we had a fairly extensive executive session last year around some of these topics, right? Right. And I thought that was helpful. And I think that our attorney had found the information on that was confidential, which is why we had the executive session as competitively sensitive. Any other public comment at this time? Okay, great. Michelle, can you remind me the schedule of when we next have LORE on our agenda? I think you said it in the beginning, but I've forgotten, just for folks on the call here today. Was it December?
Sure. We have a staff presentation on Monday, November 20th, and a potential vote on Wednesday, December 6th.
6th, right? Okay, great. Okay, well, Dr. Breisecker and Mr. Atala, nice to see you, and thank you for your presentation and your answers and your submission.
Thank you. It's good to see all of you again, and we will watch for any follow-ups from the board. So thank you very much.
Great,
And we
thank you.
certainly owe you, Michelle, a few updates, and we'll follow up. Thank you all. We appreciate the time.
All right, have a good day.
Bye-bye.
Is there any new or old business to come before the board? Hearing none, is there a motion to adjourn?
So moved.
Second?
All in favor, please say aye.
Aye.
Aye, and thank you very much, Mr. McCracken and Ms. Sawyer. Have a good day, everyone. We're adjourned.